Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. This episode's guest is Clare Nicholson. Clare has a master's in clinical research and a bachelor's degree in occupational therapy and works at the National Hospital for Neurology and Neurosurgery in London. She was the lead author on the International Occupational Therapy Consensus Recommendations for Functional Neurologic Disorders and is currently undertaking a funded doctoral fellowship at the University College, London. Links for the discussed articles are in the show notes. And with that, here's my enjoyable discussion with Clare. Well, thank you so much, Clare, for being with me today. I really appreciate the time, and it's excellent to have a full follow-up with you from our prior meeting conversation. And I'm so eager, as I'm sure our listeners are, to learn more about occupational therapy and specifically how it relates to FND. So thank you for being our resident expert on this and sharing all your wonderful knowledge with us. So let's start with the basics. So can you tell both myself and our listeners what is an occupational therapist? What are the common conditions you treat? What are the common goals you work towards? And how do you generally do that?
Yeah, so the term occupation in occupational therapy doesn't just refer to work. That is a common misconception. Occupation in the term occupational therapy refers to any activity that a person might be interested in getting back to, or that they might wish to improve their independence or ease of completing with. So that could include things like personal care. It could include domestic tasks, such as cooking and housework, or supporting community access, participating in leisure activities, educational work. And for children, occupation could also mean engaging in play, socialization, study, and life skills. And as occupational therapists, we provide rehabilitation in the context of functional or daily activities, and specifically targeting a patient's goals. And we might also assist with ensuring ease of access in the home, in the community, and educational work environments through assisting with the provision of aids and adaptations or reasonable adjustments in the context of work and study. So that's kind of a brief overview of what OT is and what we do. OTs work in a lot of different environments, and the role in which we play really is dependent on the context in which we work. We can provide treatment for any condition. So, for example, I specialize in neurosciences and FND, but have in the past worked in chronic pain and fatigue management and in multi-trauma. Other OTs might work in mental health services, any other form of rehab, such as cardiac rehab, rheumatology. We work in wheelchair and housing services and social care. And occupational therapists are involved in policy development as well, or in advisory roles for regulatory bodies. And of course, we're researchers as well. So our role is quite varied, and it really does depend on the context in which we work. In terms of OT for FND, our first priority when working with someone with FND is to really find out from the patient as to what they want to work on specifically and what their goals are. And then when we provide rehab, again, we provide rehab in the context of daily activities. So, for example, if a patient with FND has an upper limb tremor and it's impacting on their ability to engage in, say, cooking or handwriting, then we would provide rehab in this context. So looking at strategies to assist with symptom management for tremor. So, for example, tremor entrainment, integration of strategies to divert attention away from the body and into the task. And then once they've got some of these symptom management strategies down pat, we would then implement that in the cooking or in the handwriting practice, for example.
Well, that's such a wonderful initial overview, but it gives me so many questions. So first off, just in hearing how vast your field stretches, right? It stretches across so many medical disciplines, spanning neurology and mental health and physical, right? Musculoskeletal conditions, developmental conditions, which is huge. Those are such varied aspects of medicine. And then from rehab centers to law rooms and, policy positions, and research. So vast skill set and varied skill set. I'm wondering if you could talk our listeners through, and it might be different country to country, since you practice primarily in the UK and Australia, versus here in the US. What does a typical time frame or evaluation look like, from the initial visit to how many treatment sessions you can typically offer? How is that determined, or is it limited as it is in the US often by insurance? And how is that determined? And it sounds like goals are pretty collaboratively set, where each person doesn't come in with one, with the same goal, or you don't just say, this is what we're going to, work on with you. It sounds like it's much more collaboratively stated. And so how do you kind of make that determination, and how long do you have to work essentially?
I think that does vary from setting to setting, and is really dependent on the service structure in which the OT works. So, for example, if you're working in an inpatient rehab facility with patients with FND, you would really probably be guided by how long the patient has to work with you in that intervention. The same as in community services, depending on the funding for the community service, but or in an acute environment, you might only have a couple of days.
Oh, wow. Oh, geez.
Yeah.
Only a few days. That's not a lot of time to accomplish such a big goal.
No, it's not. So, the role for an occupational therapist working with someone with FND in an acute environment is quite different to what it might be in a rehab environment. So in the acute environment, you may only have a few days. Again, I can only touch on my experience of working in an Australian and a UK-based healthcare system. And certainly, generally, patients come in and they come in for a workup, or they come in acutely because they've been quite unwell and gone off their feet, or are having seizures, for example. And then an acute OT might assess the patient, really see how the symptoms are impacting on their ability to manage day to day, to manage to get home and be safe within the home environment. And then we would look at what supports might be needed to get that person home and make onward referrals as required. But the acute kind of input might be really about providing education about the diagnosis. If the diagnosis of FND has been given, that can still present some challenges in acute environments, where patients often struggle to get the diagnosis.
Yeah.
So that can be a challenge. And then we're looking at what are the barriers to getting that patient home. Can we set that person up with some basic symptom management strategies that they can learn whilst they're in the acute environment, and then once they get home, they can implement that at home, perhaps with support from some community services. But in a rehab environment, it could be quite different, because the patient probably comes to rehab with some goals in mind. Well, we would hope they would. And if they don't, then we would support them to collaboratively set goals. And then it really depends on the service structure as to how long they might be staying. So some services have open-ended rehab periods of intervention, and some services have very set, limited timeframes. And whether that's MDT treatment, or whether that's they come in specifically for a period of OT, it really depends on the setting.
What's an average length of occupational therapy time that's covered or allowed by payers within your current practice setting?
So in the practice setting in which I work in both an inpatient and an outpatient service. Our inpatients come in for MDT treatment for a period of only 4 weeks. And then we might look to discharge them with some support from community services. And our outpatient program runs over a 5-week period. of MDT treatment. But prior to them coming to us, they have a fair degree of workup in that patients have access to online support, which is a guided self-help program, and where they're really kind of talking about goal setting and self-management principles. So it's not just that period of intervention that they have with us. There is a bit of workup beforehand and education about FND as well.
Wonderful. And I'm glad to hear at least that there's multiple weeks allowed in an outpatient setting. Typically, I think that would probably be pretty parsimonious with the US. I don't think it would be indefinite here, but it would be several weeks usually. A few follow-up questions. You're using an acronym to describe something. I'm not sure myself or my listeners know what that is. Can you tell us what that is?
So which acronym are you referring to?
NBT something?
Oh, multidisciplinary treatment, so MDT, or interdisciplinary treatment, yes.
Okay. That I'm familiar with.
Yeah. So access to a specialist team of OTs, physios, psychological therapists, neuropsychiatrists, neurologists, specialist nursing. So yeah, a whole team approach.
Very helpful. Thank you. Actually, I might make that acronym catch on here in the US. We always just say multidisciplinary, and it's a multi-syllable word, and we just continue to rattle it off. Other follow-up question I had in response to some of the aspects you were talking about is when you said that individuals come in and they may or may not have goals, but they're primed ahead of time, both before and after, and they have access to this outside or additional self-help resource. Is that something unique to your clinic, or is that something that would be more widely available to other patients?
I think, well, it's unique to the service in which I work in, and every service works differently. But I do know that other services, do provide remote support to patients with FND as well. But it really depends on their service structure. It's something that our service has been working on for several years. And it really supports the patient to be primed for the rehab process.
Yeah, it sounds wonderful. What's the format of that? Is it online modules? Is it recorded lectures? Is it in the length and duration? And
no, the patients are provided with one-to-one support online, and with a specialist team of therapists that provide that support. Yeah.
Oh, so it's sort of wraparound care in addition to the therapy sessions.
Yeah, so it's literally designed to prime the person in readiness for their treatment and getting to think about the biopsychosocial framework and how that relates to the person, really discussing the links between physical and mental health and vice versa. And how our mental health impacts on our physical health, and our physical health impacts on our mental health. And the program in which I work runs within a neuropsychiatry service. So we have a very strong focus on the impact that our mental health has on our physical health. And even as a physical therapist, so occupational therapist that specializes in neurosciences, and our physical therapist specialize in neurosciences, we very much are aware of that interplay, and we integrate that within our treatment framework as well.
Wonderful. And so the member on your team providing that additional primer, is that a mental health provider, or is that in addition to their mental health treatment, they have a social worker or a nurse practitioner who's been trained in introducing these aspects and providing that one-on-one additional ongoing support?
So within our team, the people that provide that kind of priming work are mental health specialists.
Got it. So in your model, mental health comes before PT and OT.
Yes, it does as part of that priming framework. Yes,
and carries on,
and then carries on. Absolutely. That's mental health care is integral into what we do, but we integrate as physical therapists when we work with a patient. We integrate both physical and mental health modalities, and as an occupational therapist, we are trained in both physical and mental health rehabilitation as an undergraduate. So our skills are very much of value to people with FND because we can really integrate and see the value in integrating the physical and the mental health rehabilitation together.
That's wonderful. Yeah, it's a very unique skill set that's well poised for this population. And I think that's very similar to other rehabilitation models that have mental health as part of the initial multidisciplinary evaluation, start to have that process get started prior to initiating PTs and OTs, or almost as a precursor to make sure that it's a good time mentally or cognitively for PT and OT. Sometimes more robust mental health interventions are needed prior to PT and OT in order for that to be stable or appropriate. But it's great to hear that it's continuing in a wraparound model as well and started early. So early and often is a good role for mental health and FND.
Well, I mean, the symptoms of FND are so disabling and disruptive. It would be remiss to think that that doesn't have an impact on mental health. And even the symptoms of FND can be an exacerbator for anxiety and stress, regardless of whether a patient has those any mental health conditions or problems with anxiety and low mood even before they have FND. FND in itself is enough to create problems in that area.
Oh, so. Very much so. Yeah. If someone was not nervous, sad, or anxious before, they very much can become that after symptoms onset.
Absolutely.
Sure.
Absolutely.
Yeah. But you were also discussing, and this is a great segue into my next line of questions here and thing to dig in, which is when patients with FND come for an outpatient setting. So I really like how you summarized, if it's in an acute inpatient, the goal is just get people home safely. That makes sense. But in an outpatient setting, it sounds like there's much more room for goal formulation, joint goal setting. So what are your common goals, or what are common goals that patients with FND often come to therapy searching for? Is there commonalities and differences, and what generally tends to drive that, do you think?
Yeah, so there's patients do come to outpatient therapy with goals in mind. Often in our occupational therapy intervention, it really is that their symptoms are having significant impact on their ability to get on with life. And for each and every patient, that might look different. Our outpatients tend to be a little bit more mobile than our inpatients. And often they might have vocational rehab goals, so their symptoms might be interrupting their work routines, or their symptoms might be interrupting their home life. For example, their childcare abilities, their ability to run the house, their ability to use public transport. I mean, the list could go on. So, in our first assessment, we're really interested in finding out about how their symptoms are impacting on their ability to undertake their day-to-day activities, their routines. Often routines are very disrupted by their symptoms. Pain and fatigue are commonly associated with FND as well. So often that and other comorbidities can really impact on FND and vice versa. So we're not just thinking about FND, we're thinking about other comorbidities, we're thinking about the overall symptom impact and on activity engagement, but also quality of life. And of course, FND impacts on family systems as well. So, we're thinking about that person in their whole context. Not just themselves, but as part of their family, as part of their social network as well.
Yeah, it's again broad reaching and broad stretching when it comes to quality of life. And one of the things, as you were describing just the range, it's really focused on how can we make someone's life better, right? Within this whole context that they're in, it's really an intervention focused on and directly improving quality of life, which is amazing.
Yes, absolutely. And the goals, they have to be independently set and collaboratively set, because what is important to one patient might not be important to another. And you will only truly get true rehab engagement if you're working on what is personally meaningful to a patient.
Yeah, of course. And that's sort of the not sole aspect of motivation, but I imagine one of the key pillars for maintaining motivation and engagement and getting the outcome that's desired is it has to be relevant to a person and meaningful.
Absolutely. And, one of the key principles of rehab and kind of a cornerstone of occupational therapy is about self-management. And introducing the concept of self-management very early in the assessment and treatment process with the patient with FND, what they do inside their occupational therapy sessions and outside their occupational therapy sessions is just as important as what they do when you're in a one-to-one session. Because we're really looking at integrating these symptom management strategies for FND across the 24-hour routine. And that's how we get symptom improvement. That's how patients develop confidence in their ability to manage symptom flares. And, really testing these strategies out in different contexts is quite important. And then, as you mentioned, when they come back to the outpatient session the next week, we can then problem solve what went well, what didn't go well, and what do we need to tweak. Because, that's quite important to test things out in the real life context.
I'd imagine similar to aspects of a targeted mental health treatment, that there's a certain number of goals you can initially set, right? That are, we're going to target these first few to start and then hope that there's generalization and sort of internalization of the skills. And then with future treatment continuing for the patient to generalize themselves, to then use that same skill and expand it in other regions and other ways. How many goals do you generally encourage a patient to set to start? Is it 1? Is it 5? Is it 10? I imagine 10 would be overwhelming. I imagine somewhere between 3-ish and 5-ish, but I don't know. I'm very curious.
Yeah. So I guess we typically get someone to really think about, around 3 to 5 overarching goals. And then one of the really important parts of goal setting is around graded goal setting. So we look at that overall arching goal that they might have and then really break down the steps that it might take to get to that goal. Now, they might not actually get to that end goal in the period of our intervention. We might start on some of those initial steps, but then part of that intervention would be looking at how they can continue to build on each step, perhaps independently or with the support of significant others, once they leave the intervention, to continue to build on their safety, independence, confidence with whatever goal they might have set. Goals change over time. So you might be working with a patient and have some overarching goals in mind. And then once you start the intervention, the patient thinks, okay, I've got that goal down now. Actually, this other goal is a priority. So we might shift the goalposts a little bit. So it does need to be a flexible approach.
Good. Wonderful. So many follow-up questions for that. One is, if it's possible, are there common treatment interventions or common treatment aspects that sort of underlie many goals? I've heard you list some of like safety, independence, and confidence a few times here. Are those commonalities that run through? What are common strategies you use briefly just to help patients, or is each of the goals specific to, or intervention specific to the goals? I'm curious.
Yeah. So, I mean, there's a few kind of commonalities that come through when patients come into rehab. One in particular, if a patient has functional movement disorder, which is markedly impacting on their function, we would look at strategies to assist with their functional movement disorder, whether that be movement retraining, such as tremor entrainment, or getting people up and weight bearing if they've gone off their feet, for example. And we would integrate those functional movement disorder strategies or motor retraining into daily activities. Either, things like we might work in the kitchen, we might get them out walking or standing at the supermarket, we might go to a cafe and stand to order a cup of coffee, whatever their goal might be, it's quite contextual. So, functional movement disorder, and then we have patients that present to us commonly with functional seizures. Now, obviously, functional seizures can have a marked impact on daily engagement with all levels of daily activities. So that might be looking at if a patient is having such frequent seizures that they're really not getting out of the house, or they might be scared about leaving the house in case they have a seizure, then of course we would do a piece of work on seizure management. And that might be, and as OTs, I'm very blessed to work in a very skilled multidisciplinary team where I'm supported by neuropsychiatry and mental health specialists. So as a team, we would look at strategies to help manage seizures. But some OTs are working in isolation. And so as an OT with seizures, you might initially looking at grounding strategies to keep people present in the moment, to prevent dissociation. You might look at some of the triggers to functional seizures, such as anxiety or stress, and look at anxiety and stress management strategies. Other triggers that commonly can trigger seizures might be sensory input or hypersensitivity to sensory input that they might be getting. So we might look at strategies to help with that. And of course, seizures cause a lot of fatigue and pain. So alongside that, we would do probably a piece of work around fatigue and pain management as well. Yeah.
Oh, go ahead.
No, that's okay.
I have a follow-up question because I always am curious about this, and my patients will ask, and I want to be sure I'm giving them OT-approved recommendations. So especially for sensory sensitivity, that is such a common symptom, complaint, comorbidity. I'm not sure where exactly it falls on that spectrum of feature of FND or a way it manifests. And that is one of the main reasons why, individuals list that they avoid activities outside their house, right? They don't want to be exposed to certain noises, lights, sounds, like grocery stores, ambulance sirens, concerts, all these things that, previously gave them a lot of meaning or sense of accomplishment. Now, in terms of best practice strategies, is it a combination of symptom exposure to try and decrease reactivity, as well as environmental modifications such as like noise canceling headphones and things like that? So how much and how is that determined between, manage the response versus manage the stimuli, right?
Yeah, so yes, so many people with FND do experience difficulties with sensory hypersensitivity. This could be hypersensitivity to light, sound, touch, movement. So it's a common symptom of FND, but it's also very common with other comorbidities such as fatigue, pain, chronic migraine, and many people with neurodiversity also experience difficulties with hypersensitivities as well.
Yeah. And post-TBI as well, post-traumatic brain injury is very similar.
Of course. So as an occupational therapist, what we would do is work with the person to identify the impact that the sensory hypersensitivity is having on their engagement with daily activities. And we might do this initially by reviewing their 24-hour routine. And we might also use a formal outcome measure. So commonly we would use the adolescent-adult sensory profile tool. And that helps us to identify the impact of the symptoms, but also the person's sensory preferences. So what do they kind of move towards in terms of sensory preferences? What do they avoid? And using that, we would then work with the patient to develop a personalized graded sensory exposure program to try and increase their comfort with everyday sensations within their routines and increase their engagement inside and outside of the house, for example. So for some people, this might actually involve gradually reducing the use of compensations, such as sunglasses indoors or the use of headphones. But for others, this might be introduced as a starting point to increase engagement, and then making a graded plan together to gradually reduce the use of compensations.
Mhm.
And for people that might be neurodiverse, the use of compensations might be really helpful and might actually be the difference between engaging in an activity or not. So it really has to be made, that decision has to be made on an individual basis. Some of my occupational therapy colleagues in the US, Jessica Ranford, Julie McLean, Catherine McCombs, alongside David Perez and his research group, have particular expertise in the area and have written several papers on sensory modulation difficulties presenting in people with FND and how OTs can help in this area. So if listeners are really keen in learning more about sensory modulation difficulties for people with FND, then their papers can be readily accessed online.
That's so very helpful. Thank you. I will feel much more confident when I tell my patients what I generally say, well, it's usually a combination of, trying to decrease reactivity, but also if needed, develop strategies that'll help you, compensate or be around those stimuli more comfortably. So I'm glad I'm not wrong. But also importantly, go to OT. So to hopefully identify a very specific protocol that might overall help. And it's wonderful to hear. Thank you. One thing as you're speaking about this is that I think is pretty unique to occupational therapy is you're so involved in people's lives in the minutia, right? You're in the minutia of their, in a way, it's a lot like the privilege of mental health, right? Where we're allowed into parts and spaces of people's lives and experience that are not part of the normal social, exchange. Most people aren't privy to someone's 24-hour log of daily activities. And it's a very privileged and almost, kind of private, experience to be allowed into that element of that much of patients' lives, right? The details of their lives, of their day-to-day activities that are so meaningful and so important. I know in mental health, we talk about such at times very important core issues, and it's the same in occupational therapy. It's just also the core meaningful pieces of their daily lives, right? That give them their sense of joy, quality of life, meaning in life, whether or not they can go be around their grandkids, or
absolutely
spend time with their families or be at work and do something that they love. It's just so central to well-being as well as just like a human and personal connection that I think is a really unique element that you might offer. That's a bit different, I think, even than like physical therapy or speech therapy that's often done, within the practice setting and focused on very specific things and not as personalized. I mean, walking is very personal, obviously, but it's just a different lens and a different element of life that you're involved with in such an intimate way.
Yeah, and I think that the assessment of the 24-hour routine is a really key component of an occupational therapy assessment for people with FND. Because really when I'm doing that, I ask a patient, okay, take me through a typical day on, we probably would look at a day where the symptoms are not so bad versus a day where the symptoms are, they've got a flare of their symptoms, because those days can look quite different. But really, what are they doing from the time that they're getting up to the time they're going to bed? And that can really tell me as an occupational therapist a lot. So how engaged are they? How much time are they spending in bed? Are they spending prolonged periods of time during the day sleeping? Are they spending time in communal areas of the house? How often are they getting out of the house? If they do a piece of housework, does that put them in bed for the rest of the day? It tells me a lot, and that really forms the basis for where we can start to intervene. And really highlights some of the problem areas that a patient may not even be aware that it is a problem.
Yeah, exactly. But what bravery, I'm always just so impressed by our patients and, how they come in and just kind of open up, and just kind of give us, just give us this unfiltered access to these very private elements of their lives. When you get up, well, what do? Do you brush your teeth first? Do you make your coffee first? It's like, well, what business is it of yours, lady?
Yeah.
But when it comes to our professions, these are questions we ask. How does it make you feel when you make your coffee in the morning? Well, who cares? What business is it? But I really think I'm always so impressed by our patients' bravery and openness and willingness to put these elements and these parts of their lives out there for relative strangers, to try and assist with. Oftentimes to good benefit. We try and do our best and be, we're non-judgmental and we really want to help. But it just is an odd thing, to be so in so many details of someone's personal life. And I'm wondering, we've seen when it's very successful, right? When someone comes in and they say these things and you can make insights and they can develop strategies and obviously generalize and implement those. What are common barriers? I know sometimes we don't like to talk about barriers as often because we like to hear the success stories and when things go well, but there are times, and I really appreciate in our last FND conference where we did highlight, sometimes people don't make the progress we would hope, or they don't get better. And it's important to still maintain a sense of, reasonableness about that and patient engagement and, provider engagement, even if people are struggling. So what are the common reasons, especially from an OT perspective, where people might struggle, or common barriers you see? And some of these, I imagine, are outside of people's control, like their psychosocial circumstance or different aspects of external life or other health factors. But from your perspective, what's been your experience with barriers or reasons people might not be able to be as successful in OT?
Yeah, so that's a really good question. Of course, that's different for every patient, but sometimes it's about timing. And sometimes when a patient comes off a waiting list and finally gets to participate in rehab, it might not be the right time for them. That could be because of a number of reasons. It could be that there's a lot of things going on socially for them and their focus is on the social aspects rather than on treatment. It could be that actually the FND is not the priority. Perhaps it is a mental health problem that requires some intervention in the first place before then they can be successful in targeted FND rehab. Pain and fatigue often interrupt rehabilitation. And when we think about that as therapists, we need to really think about that carefully and how we grade their therapy, particularly if we're providing physical rehabilitation. Because pain and fatigue can really impact upon the pace at which successful rehab can be delivered. So it may be that when we're thinking about goal setting, if pain and fatigue is a significant comorbidity, we might need to reset expectations and really think about the amount of time that we might have to work with somebody and what's realistic to be achieved within that time period. So I think they're probably some of the main things. It's about timing as to what else is going on in that person's life. Any other sort of mental health problems that might need targeting prior to undertaking some rehab, and pain and fatigue management. And it could be, Erica, that someone needs some more targeted pain and fatigue management intervention prior to undertaking, say, physical rehab for a functional movement disorder, for example, for that bit of intervention to be successful. So when we're assessing a person, we're really thinking about all of these things. Is it the right time? Are there other comorbidities that need targeting prior to thinking about FND rehab?
Great. Yeah, exactly. And those are such important comorbidities within our biopsychosocial model to be mindful of. But again, I think it's just also patient education and provider education around why certain models might not be, or interventions might not be appropriate at this time, which is useful. One thing on the other end of the spectrum, as you were speaking about that, and one thing you mentioned before was sometimes the goal is actually return to work, which is sort of the opposite end, right? People are doing so well that they might be considering returning to employment. But oftentimes, or at least here, we recommend going back at, a gradual way, or, starting out part-time and gradually building up, or going back with accommodations for their FND. And different employers have very different levels of responsiveness to these requests. What role, at least in your setting or that you're aware of, do occupational therapists generally play in return to work determinations, return to work accommodation recommendations, and direct communication with employers, or provision of, here in the US, we commonly, write a letter and say, this is what should be provided. Employers may or may not kick that back to us with their opinions about that, and we try and work with them. But what role do OTs generally play in that?
So OTs have a big role in vocational rehab. And in fact, there are specialist vocational rehab services that are kind of headed up by OTs and psychological therapists. So, but in terms of F&D, we might have a role in supporting either a phased return to work, or even reintroduction to study routines as well. It depends on the age group of the person that you're working with. But commonly, some of the key factors about vocational rehab, if we're thinking about work, would be about identifying the impact that symptoms are having on work routines, and then looking at what strategies that we can help to implement to help support symptom management, and then how those symptom management strategies can be integrated into work routines, either independently for the patient, or they might need some support from their employer to implement reasonable adjustments. So an example of a reasonable adjustment might be looking at flexible working patterns. So perhaps either having a couple of days working from home and a few days in the office to help manage fatigue levels. It could be starting work slightly later so they avoid having to travel on a peak hour train and being exhausted by the time they get to work. It could be having regular rest breaks integrated into their working day, or delegating certain tasks that they might not be able to manage. If we're thinking about study routines, for example, for school, it might be working with the school to develop a symptom management plan for study routines, or having assistance to sort of get from A to B, from the classroom to classroom. Occupational therapists have a really significant role to play for vocational rehab. So it's something that we do quite a lot of.
Yeah, it sounds like that may be an independent, it may be its own independent specialty, vocational rehabilitation, occupational therapy, or it may be a goal within, or a primary goal within a person with FND's OT treatment, right? If that's one of their primary goals, which would be amazing.
That's correct.
And I want to be mindful of your time. I know we're needing to wrap up, but I'd really just like to end and highlight the range at which you have covered in your specialty, from when a person is acutely hospitalized, how do they go home safely, literally physically safety, to perform, basic daily tasks, to, when they're back at work, and what role and strategies they can use within their day-to-day work environment to make sure that they can stay employed and navigate their work day in an appropriate. That's just such a huge range of skills and knowledge that you have in order to be able to help patients with FND from such a spectrum of, when they're leaving the hospital to when they're back at work, riding the train to work. And that's such an amazing skill set to have, and such an asset for patients to be able to access and get benefit from.
Yeah. And sometimes work can be a significant exacerbator for FND symptoms as well. So it may be for some patients with FND that work is not sustainable. And, the next step for OTs is to help patients to success. If that is the case and returning to work has been trialed and it hasn't been successful, then it may be that OTs help them to support them to stop working, but then re-engage in other meaningful roles, whether that be in a paid or unpaid capacity. So maybe that particular job role is not quite right for them given their current circumstances, and maybe we can look at retraining options or other work opportunities, or maybe it's about re-engaging with some voluntary work to do some work hardening. So yeah, that role can be quite varied, but you're right, our occupational therapy role is very varied.
It's
so
wide stretching.
It's perfectly matched to people with FND, I think.
Yeah.
I am biased, but
I think with good reason. With good reason, you are biased to think that you're perfectly fit, as occupational therapists, given the breadth and scope that you cover in terms of diagnoses, comorbidities, physical, mental health, social involvement, from acute care settings to, return to work or even disengagement from work. It's just such a wealth of knowledge and an amazing asset for our patients with FND to have access to. So I am so grateful for you taking the time to have this chat with me and confirm some of my understandings and recommendations for my own patients I now feel better about. But also I just feel like I've gained such a better appreciation for just the range and scope of care you can provide and how important that is. So thank you so much for taking the time, and especially our listeners. I hope everyone takes away as much appreciation of your specialty as I definitely have. So thank you.
My pleasure. Thank you.
Thank you. Okay, there's a bonus bit for those of you who waited until the end, because Claire and I also spoke about the use of assistive devices. This topic often comes up when discussing rehabilitations with patients and care providers. Keep listening for that discussion. So, additional topics. We mentioned aids and adaptations and OT's role in, one, and for me and our listeners, what are common aids and adaptations and how are those assessments usually made, and then how that's specific to FND.
Yeah, so occupational therapists and physiotherapists actually are commonly asked to provide aids and adaptations for people with FND. And what we would generally there's a few recommendations and things to think about. One is that the provision of aids and adaptations should really be carefully considered on an individual basis, and to really clinically reason as to what that aid or adaptation might afford that person. So, and that might depend on the stage at which that patient is. So if a patient is presenting acutely, so they've only had their symptoms for a very short period of time, you really need to weigh up the pros and cons of providing that piece of kit. So sometimes you need to provide a piece of equipment in order to get the person safely home. And if you do need to provide equipment to get someone safely home from the acute environment, say hospital to home, then you really need to be thinking about providing equipment using a minimalist approach. So less is usually better to start with. The person should, of course, be taught how to use the piece of equipment properly, so as to prevent secondary complications such as pain. And a plan should be made as to how that person can move away from using the piece of equipment over time. So that might involve handing over goals to community therapy teams, for example, with the goal of moving away from using aids. And also, if a patient has had their symptoms for a long time, then perhaps a piece of provision of aids or adaptations in the home is necessary to improve quality of life, ease of access, independence. So again, that needs to be weighed up on an individual basis. Now, one of the important things to think about with provision of aids and adaptations for FND is that often patients with FND don't just have their FND symptoms, they also might have other comorbidities impacting on their function and quality of life. But sometimes those comorbidities are exacerbators for the FND. So again, on an individual basis, weighing up, would a piece of aids and adaptations help to support management of comorbidities and therefore minimize triggers for the FND symptoms? So that's something to really think about. Sometimes they don't need a piece of equipment for the FND, but they might need something to manage a comorbidity that then flares their symptoms. So I would just really stress that there's no hard and fast rule for provision of aids and adaptations. Where at all possible, a patient should be offered rehabilitation to try and minimize the use of aids and adaptations, of course, but we're very much aware that internationally, the provision of rehabilitation is not always possible for all patients. Services are oversubscribed, and it can be really hard to access rehab. So sometimes providing a piece of kit is the difference between functioning and not functioning. So really important to consider as part of your clinical reasoning as an OT, what that piece of equipment might afford that patient. Can you look at an alternative? And if you can't, what can support function?
Mm-hmm. Yeah, so it's a very much individualized context and contextual consideration of aids and adaptive equipment that is also impacted by timing, access to services, comorbidities, responsiveness to intervention, maximizing, independence and minimizing adaptations, but also, improving what's really going to relate to quality of life for that person. Yeah, absolutely. Not a simple yes or no question by any means.
No, yeah. And in the consensus recommendations in the long version, which is available as supplementary information online, there are clinical reasoning tools and case studies for provision of aids and adaptations. So not everyone is aware that there's a long version of the consensus recommendations as well, but that's in there if people are interested in looking at that further.
That's great. Thank you. One other piece that we'd also wanted to talk about was the differences between OT for pediatrics and adult populations, and nuances to perhaps be mindful of, as well as different consensus recommendations or elements.
Yeah. So my experiences of working with people with FND from ages 16 and above, and the treatment for adults or people of transitioning ages with FND and children, there's obviously going to be quite significant differences. Mm-hmm. So I know that the adult consensus recommendations for FND have been used by pediatric services, but adapted for their own use. So it's used as a framework to work from. Mm-hmm. But specialist recommendations for children and young people are needed. And that's a work in progress, and it's current pediatric consensus recommendations for FND are just getting started, and being led by a fellow OT in the US called Jason Krautsman, which many of you know. So watch this space. There's a group of us working on those recommendations. So hopefully in the next little while, we should have something up and published.
What a range, right? Again, the range from adults to children to, the start of life to the end of life when it comes to maximizing independence and daily functioning. It's just such a huge scope and breadth of practice that your field covers. It's amazing.
Yeah, absolutely. And, FND doesn't discriminate. It affects people of all ages. Mm-hmm. So as OTs, it's really important to have a breadth of skills to go across those different age groups, but we would all have our own specialisms, so we have to draw on skills from each other.
Mm-hmm. Oh, this was so wonderfully helpful, and I think we've covered such reflective of your practice. We've covered such a range of questions and aspects related to FND and daily functioning, and I'm sure my colleagues will really appreciate just having this more detailed knowledge about your wonderful specialty and its more nuanced practice, and we can be more mindful of what we're educating our patients on, and making explicit referrals for OT and advocating for, the role of OT, especially in the U.S. being covered, at especially longer timeframes as well, given it's can really change from acute to longer term settings. So it's wonderful. Thank you so much for your time, Clare. It's always a pleasure talking with you and hearing about your great work. So thank you.
Okay, my pleasure. Thanks, Erica.
Thanks. Physicians and providers treating functional seizures, we invite you to participate in a brief survey examining driving recommendations for patients with functional seizures. Developed by a dedicated study group, this survey seeks to capture the current opinions of physicians worldwide on this topic. Please take a moment to share your experience. A link to the 5-minute survey can be found in the show notes.